everybody. Actually, this is the complication from the masters under the recipe of GTCI, EGIC, Pesky, and CardioRx. Actually, this is the most important session. I know everybody is looking for it from these 2 days, and you have the most eminent intervention cardiologists who know how to treat complications. The predictors and how to treat them. Most important person is Eric Eckhout. Eric Eckhout's working in CHUV when I was young. He wasn't there at that time. I was in 1987 working in CHUV, the most important hospital in Switzerland. And Eric is the head of the department. He's a very nice guy. He looks nice, but he knows how to do the champion of the treatment of complication. And we have with us also Kamal. Kamal had a book about complications. And Farrell Helling, Antonio Colombo, waiting for him, Max Van Moor, Horace Sievert. With me, the chairman is Eric, Antonio Colombo, Kamal, David, and myself. I think we are waiting for Habib. Habib is doing a complex case and hybrid case on alcohol septal ablation. He will join us at the end. I will start to introduce Eric. Expect the unexpected. It's an interesting title. So we are waiting for the expectations, Eric.
Okay. I'm going to share my screen. So indeed, I call this case the most you asked me to present basically the most educational case I encountered. So over my career, that's a difficult question. So I had to make a choice, and I choose this case because it's a patient that I learned to know and treat, and I learned to meet his family, his children, and so it impacts a little bit what will be the outcome of this case. Sorry. So before coming to my case, I would just like to show this and making some allusion to our friends from South Africa. This is a slide from Eddie Horrick, and it really illustrates our profession, and you see the balance between confidence and competence. And it's a bit strange to call us the masters because we are basically simple guys. But anyway, I think this slide is very nice. I don't have much time because in 10 minutes I'm supposed to present my case. But just look at it and think about it, and try to imagine where you put yourself. Although we all tend to put ourselves at a higher level. So let's come to the case. It's a young man. He's 49. And I met him the first time in February in 2015, basically. And I had to treat him in February 2017. So it's a case of about 3 years ago. The patient has a quite exceptional, rare genetic kidney disease that basically leads to terminal kidney renal failure at the end stage of this disease. And probably in the setting of this disease, he had previous mitral valve repair by a mechanical valve. He had 2 bypasses, so severe rheumatic and ischemic heart failure. And we closed in 2015 3 parallel leaks. I'm going to show that here. So you see very nicely the 3 leaks. There is one almost retroaortic, there is one lateral, and there is one posterior. And we were able to close these leaks. This is the way we quantify the leaks. Very important to have your echo guys at top level that really help you to decide which device to use. So we do this procedure transseptal retrograde, and you can see basically the different plugs that are located and that were able to close the leak quite nicely. So all fine at that stage, but basically the patient, as mentioned, comes back in 2017. Basically in 2016, just to go a little bit further, the patient had totally AV block, needed a permanent pacemaker. And in December, basically he had anginal symptoms, and we had to retreat every bypass of this patient. So basically we treated the valvular problem, the mitral, we treated the bypasses, and it was a quite sad story of this patient that basically had chronic problems. Now the major issue comes to February. That's when basically the problem and the complication occurred. The patient had syncope, persistent symptoms, and basically we diagnosed this patient with aortic stenosis. The mean grade is not 30, but anyway, the decision was that this patient needed treatment for his aortic stenosis. And the decision to treat him was not easy. We have our valve board meetings, and initially we decided to go for an evolute arc before, but we were basically at that time waiting for the EC approval, and we could not implant the valve. And then, for some obscure reason, the board decided to change for surgery, because the idea was he's young, he's only 49, and maybe there is a plan for renal transplant. So I was basically not very convinced. I was quite concerned about surgery in this patient. And basically, the patient didn't want to get surgery. I talked to him, I saw him with his family, his kids, young kids, his wife, and they said, surgery never worked with us, so you need to convince me. I said, but no, it will work. So basically, we needed several doctors to convince him. And then finally, he accepted to go for surgery. So the patient was taken to the ER, and unfortunately, what we expected happened. Basically, 8 hours of surgery, and weaning was basically impossible. The patient was in profound shock. And the only thing they decided to do is to put the two simultaneous complex ECMO systems and counterpulsation to more or less support the patient. So that's the situation at that time. And now the issue is the following. I think for the sake of time, I'm not going to ask you what's going on, but I ask you to have a close look at the posterior plug, the plug tree, in this patient before and after the surgical intervention by our colleague, the surgeons. And basically what happened, you can see it over here. So quite incredibly, 2 years after the implantation of the plug, this plug moved and blocked one of the leaflets, explaining the shock in this patient. So probably this is related to the unloading of the heart during the support of this patient. We don't have a clear answer for that. But anyway, that's the problem. So the question is definitely the following: what can we do for this patient? Just to have you a view of the drugs that this patient had. I've never seen a cocktail of so many drugs, and you will see that this had an impact on the final outcome of this patient. That you see the impressive doses of drugs that this patient was receiving to keep some pressure despite the assistance that he had. Now, the question is, what can you do for this patient? And I think I learned more and more during my career that there are some patients you can't help. And potentially this patient is a patient where nothing can be done, and we just should have the patient go. But the patient is only 49. Or we go to the ER, but the surgeons say no. And I think the surgeon is right. And then the third point is go to the cath lab. But the point is, what can you do? Basically, what can you do? Of course, to be honest, I had already some ideas, and I must confess that there was a quite challenge to think about doing something for this patient percutaneously. And the thing that has to be done, of course, is to try to get this thing out, to pull out this posterior plug, and then solve the problem of the blocked leaflet. So our initial plan was the following, and that's to go basically transseptal, to use the Agilis catheter, and then try with the biotome to pull it out. Now, already the first problem we had in this patient is to find your way through the forest of catheters and wires or whatever to see where is your needle and to do the transseptal. Of course, we did this with echo guidance, and basically we were able to do that. And here you can see basically the attempts to capture the plug with a biotome. And as you can see, this was partially possible. We were able to partially unblock, but we could not maintain the result. And to be honest, a biotome is not solid enough to grasp the thing. And definitely, I thought it was not a good idea. So the question now is, what can we do? Stop there and think, this is the end. But no, my idea is that we need something more solid than a biotome. So I asked the nurse, do we have something more solid than a biotome? But don't forget, we are in the left atrium, so we have to be extremely careful. So the nurse came to me and said, we have something, have a look at it. So the device is called the Raptor. So I'm going to introduce you to the Raptor. The Raptor is this device. It's a very big, horrible device that is used in gastroenterology. And of course, it has never been used, I think, in cardiology. But I like the device. It looked, as you can see, used in gastroenterology. It looked very nice, and it looked probably to have the potential to potentially grasp the plug tree and pull it out. So this is the Raptor through the Agilis, as you can see, trying to trap it, but basically the only thing I can trap is the annulus of the valve. So we said we need to stop there. So I basically told my team, it's time to stop now. We're going to get into trouble. But then one of my colleagues said, Guy, if you stop there, the patient is going to die anyway. So why don't you try another approach? And I said, not just serious, because I know what he was thinking about. So you don't want me to go transapical? He said, of course. So that's what we did. So I did a transapical puncture, which is basically quite easy. Just ask your echo guy to show you the window, and then you just puncture. It's easier than puncturing basically a radial or femoral artery punctured. And I basically decided to use a new Agilis to put it in front of the device. And here you can see basically the Agilis in place, the Raptor that has tracked the plug. And look carefully at the next image, because here you're going to see that we were able to pull out the plug just now. If you look carefully, also you see that there's a wire over here. This is a V18 wire that I put as a safety wire into the whole structure. But at the moment I pulled out the plug, I said, what I'm going to do with this plug now? I just can't take it out of the heart. So at the same time, by the time I pulled on it, in a fraction of a second, I said, I'm going to use this to plug the entry side of my Agilis, which basically was the next step. And this is basically what you see over here. So the deformed plug 3 basically was used as a plug to plug the hole at the apex. And I used an angioseal 8 French on top to secure it. And that's it, basically. Here you see the setting with the Raptor and the Agilis at the apex of the patient. So we stopped there. It took some time, as you can see. And you can see the deformed plug. And the patient basically improved. He improved, and for 5 days he was on a good way. But then the patient, once again, the cold situation declined again. And basically the reason was the parallel leak, believe me or not. So I got a request to close the PVL again. That's what we did. You see the catheter here across the leak, and we are implanting a smaller plug at this stage. And look carefully at the position of the marker over here. So the result was nice. The leak was closed. The V wave went down. Everybody was happy. And I released the plug. But guess what happened? Basically, the plug after 5 minutes slipped again into the tunnel and blocked the leaflet again. So what did I do? Well, as I learned from 5 days before, I used the Raptor again. And using the Raptor, I was able to mobilize, as you look carefully there at this marker and this marker, I was able to mobilize it back into the tunnel and to unblock the valve. And that's it. So that's the result. Now, what is the, just to let you know, because of the laceration of the intratracheal septum, I had to put an ASD device in this patient to finally close that, because there was a risk of right to left shunt. So this is the final situation. If you look at this patient, how many plugs he has? This has 3 PVLs. He has a plug at the apex, and he has a plug in his intratracheal septum. So what was the outcome of the patient? I'm coming to the end of my presentation. He stayed 7 months in intensive care. He needed a double ankle amputation because of all the inotropes he received, but he recovered. He recovered, and basically he was doing quite well. And he was basically for 2 months in internal medicine department. This is clearly before the COVID times. But what was the final outcome? Let's see at the price ticket. This is Swiss franc, about dollars, I would say. This is my estimate of what this procedure and this treatment of the patient costed to the Swiss society. Now, what was the final outcome? The patient was found dead in his bed on a morning in September. So several months later, the patient passed away. What are my conclusions from this case? Very simple. I think you need to stick to the initial decision of the valve board meeting. And on the other hand, I think what I learned in this case also is that he probably never should have embarked in this procedure, because I have the intimate conviction that I did it to some sense to push the limits, and I would say polish the ego is maybe a little bit overkill. But I learned from this case that we need to stay humble and think twice. And I will certainly never do this again if I'm facing this problem. Thank you very much.
Thank you, Eric, for this nice. In our country, we'll do the first statement. You said either we cannot treat any patient, go to surgery. I will take the first one because it is technically it needs so experience. I don't know the Raptor before. You as a person, the intervention cardiologist, famous. You don't know this Raptor, but I know that your nurse is working with the endoscopy. How do you know this?
The nurse gave it to me. He said, "Why don't you use this?" And I looked at it, and my whole team said, "You're crazy." I said, "But that's the only thing they can do." The incredible thing is that I didn't cause any damage with the Raptor. To be honest, I used the Raptor 4 or 5 times more. I used it to pull out a left atrial appendix occluder that was about to embolize. So I used the transeptal to pull it out. I used it in other cases. I don't remember, but several times successfully, because it's basically much more solid and to some extent, if you use it carefully, more effective and not that unsafe, I would say.
David and Kamal, Keith, any question?
What is the size of the sheet that you need to introduce this Raptor?
8 French.
8 French.
David?
Yeah. No, just an amazing case, Eric. Thanks for sharing it. I mean, it's an incredible demonstration of what technology can do, and I think all the philosophical questions are what remain. What we can do and what we should do are not always the same, and that's part of our job as well, making the what we should do questions. So, thanks for sharing that interesting case.
My pleasure.
Kamal?
What I can say, it was also, I don't know, it involved me as not as only as a doctor, as a physician, because I met his wife, his young children, and to convince them to go for surgery. We should have done a TAVI, but nothing would have happened. This patient would be still on his feet, literally and physically.
Eric, from my point of view, you've done a fantastic job. This was an incredible case where you have gone through the maximum possibility for this patient to pull him back from his, give him another life. And you did your best. So if he could have been the other way around and he would have been alive today, we don't know that, what the outcome is going to be. Obviously, he did last for good 7 to 9 months. And he kept on recovering from, came out of ITU and then went to internal medicine. So from your procedure point of view, you've done well. Probably he died from other multi-organ failure rather than just from the cardiac disease. I don't know the cause of death.
He had a sudden death because I met him in summertime. I saw him in the public cafeteria, and I had a coffee with him. So he was well. He was in a wheelchair, but he was well, and he had a sudden death. So yeah.
Yeah, I mean, he had advanced coronary artery disease, didn't he? I mean, he had degenerative grafts, multiple stenting, left main stenting. He had many possible issues.
Did he have postmortem?
Yeah, they did an autopsy, but I don't know the result. I didn't get the result. I didn't see it.
Okay. Any question again? Thank you very much, Eric. You join us till. Are you going to leave or join us?
No, I stay. I can stay until 2:00. No problem.
Okay. You can introduce the second speaker because you are chairing session.
Oh, it's my privilege to see back Farrell. We haven't seen for a while. Where is Farrell? I don't see him on the screen. Where are you, Farrell?
Farrell with you. Okay, with Kamal. We can introduce Kamal. Kamal with us.
Can you see me? I'm on the screen.
Okay.
There you go. So, Farrell, your turn. Show me a better case than mine. Show us a better case than mine.
So I think you were a bit harsh on yourself there, Eric. I think your case, you did the right thing, personally. I think you were in a situation where you were back to the wall. It wasn't your decision to not do TAVI, and I think you had to help the patient. Of course, the bill is another question, and that's a more philosophical one, but I think you did very well. I don't agree that you made a mistake of judgment there. So if I can just go to my case. Now, I'm in a slightly tricky position here because I was asked to show a case which was the most educational case in my career, and I didn't I wasn't given the brief that this was supposed to be a complication. So this is not a complication case, but it's a case that I've known for 30 years as a single patient. And I'm going to tell you what's happened to this patient over 30 years. And this discussion is not so much technical, but more one of a philosophy of how our discipline has evolved over the last 30 years. So what I hope to show you is that intervention does make a difference to patients. It does prolong life and give them quality of life. The role of clinical judgment, that the things that we are told are dogma don't apply to every patient. That intervention is dynamic and exciting, and the evolution of interventional therapeutic options have how much it's evolved over time. And despite re-intervention, therapy is durable, and one can learn a lot from a single patient. And these are the stories that keep us doing our challenging but wonderful work. So the patient is an 86-year-old male who I first saw in 1991 when he was 55 years old, and I was a cardiology fellow, and his son-in-law-to-be was my co-fellow and asked me to look after his future father-in-law. His daughter, and the patient was seen in 1991 with stable angina and underwent bypass surgery in 1992 when he had an IMA to the LAD and vein grafts to right coronary, OM, and diagonal. And these were his clinical factors, which I won't dwell on, but just to mention that he was not diabetic. And he remained well and symptom-free for 14 years after his bypass surgery. In 2006, then, at age 70, had severe lifestyle-limiting angina, class 3, for the past 5 months. The GP added nitrate to the therapy, but he remained very symptomatic. He had a normal LV, partial left bundle branch block on his ECG, and he did a treadmill test with severe angina despite a low heart rate. So, I only have still images of the angiography at that time, but he had a patent IMA to the LAD and patent grafts to the right coronary and the OM, and an occluded native left coronary at the left main. And what his problem was occluded saphenous vein graft to the diagonal, which was presumably chronic because he had had 5 months of symptoms after a sudden onset. So we told that diagonals don't cause severe symptoms and they're unimportant and you don't need to worry about diagonal arteries. Well, there was no other explanation for this patient's severe angina, so any severe lifestyle limiting angina. So diagonals can sometimes cause severe angina. We also told that saphenous vein graft PCI, particularly to a totally occluded vein graft, is of no value and won't last. But this was the only option to us with our skill set at that time many years ago. So we did a PCI to the saphenous vein graft with a AL2 guide, 6 French distal protection, and placed a cipher stent in the proximal vein graft and treated the remainder of his diagonal with balloon only. So you can see here 1.5 over the wire balloon, cross at 100 wire, pre-dilatation, spider, and cipher placement in the proximal vein graft. And then you can see the native vessel beyond there's the vein graft. Now that it's open, you can see the lesions in the native vessel, which were treated with balloon only. And this is the final result. And what I want to try and highlight is for you to understand the anatomy, because this is going to be important for the images you're going to see later. So this is actually where the red arrow is the bifurcation point of the diagonal, and this would be the natural course with these orange dotted lines of the diagonal, but this is actually tenting of this branch where the anastomosis is, which makes this look like the diagonal vein graft is placed on a carina of a bifurcation, but it's actually simply tenting. And this is the distal LAD with competitive flow. The result of this intervention was favorable because the patient had no angina for the next 7 years with normal effort tolerance and excellent quality of life. So then in 2010 at age 74, he had 6 sinus syndrome and he ended up having a pacemaker for that, dual chamber pacemaker. But importantly, a relook angiography at that time demonstrated patent graft 4 years after saphenous vein graft PCI. Then some 2 years after that. I'm sorry, I'm trying to just get my screen better so it's not obstructing my slides. Let me just minimize this window. Yeah. So he had atrial flutter with successful flutter ablation. Then in 2013, at age 77, he had a ACS non-STEMI on holiday and had a more distal stent to the diagonal graft at another center, and this is 7 years post the saphenous vein graft PCI. So this saphenous vein graft total occlusion lasted 7 years, and then a month later he presented to us with recurrence of angina, exactly the same as prior to his first PCI, class 3 angina, and angiography demonstrated a patent IMA. Once again, the grafts to the RCA and OM remain patent, occluded left main, and his new problems with this saphenous vein graft had now finally occluded 7 years later, and he had a new LAD lesion beyond the IMA and anastomosis. So what you see here is the saphenous vein graft to the OM, which was still patent, the saphenous vein graft to the RCA, which was still patent, and the IMA to the LAD. And you can see retrograde filling now of this diagonal and the new lesion in the LAD. So this is a still picture showing the anatomy. We have the native diagonal here in red. In orange, the saphenous vein graft site anastomosis to the diagonal with tenting of this branch. Then we have a tight proximal LAD, proximal to the IMA anastomosis. This is the IMA, and this is the new LAD lesion, more distally in the LAD. So now we have to recanalize this diagonal, which is causing all his symptoms. And I think reopening the graft was not regarded as the ultimate option. We had now developed skills in retrograde CTO, and this is a wire down the IMA, a fine cross delivered to the distal cap, and a tip injection through the fine cross at the distal cap of the occluded LAD. And now you can see in this view the fine cross across the distal cap, true to true, is in the true lumen, in the more proximal left main. And here you can see the left main totally occluded at the ostium, just a tiny stump enabling us to engage a catheter. And here we see a Conquest Pro 12 across the left main and a Conquest Pro 12 retrograde, two Conquest Pro 12s. Retrograde exteriorization of the wire into the aorta. And then today we would not do an antegrade injection like this, but this was early days of CTO, and we've learned now this not to do antegrade injection in the dissected vessel. But at that time, you can see now placing the stent up to the origin of the diagonal from the left main, and then stenting of the left main itself. And now we've stented the LAD up to the origin of the diagonal. We've got extension of the dissection into the diagonal, perhaps from the antegrade injection. And now we have to wire the diagonal. So you can see the severe dissection into the diagonal, and use the knuckle wire ADR-based wire-based ADR mini-star technique to enter the true lumen of the diagonal. And now this is final post-stenting of the diagonal. The one limb is visualized, the other limb we don't see at this point in time. But this was where we stopped at that point and came back 1 month later for a staged procedure because we still had to treat the LAD lesion. So now you see the residual dissection in the diagonal, which was not covered by the stent. We've got patent diagonal. So, but we also had to treat the LAD. So what we did is wire the native LAD via the left main, deliver the stent to the distal LAD via the left coronary, but visualize the landing zone via the IMA. You can see the stent now in position. And then you can see post-LAD stenting. And then we went on to treat the diagonal, wire the diagonal, and stent the residual dissection in the diagonal. And this is the final result following stenting the diagonal. So we've now got a patent native coronary supplying the diagonal, and the lemur continues to supply the LAD. Then 1 year later, he came with mild recurrent angina. The lemur remains patent, filling and the stent in the LAD is good. The left coronary, there was suspicion of stenosis at the diagonal origin. This is in a caudal view. It looks like it may be slightly stenotic. So, sorry, wrong button. So we did FFR, which was 0.8 in the diagonal, IFR 0.9, and IVUS demonstrated the ostial diagonal to be not fully expanded. So we did high pressure balloon inflation followed by drug-coated balloon into the LAD and diagonal. And this is a final shot after that procedure with simultaneous Lima injection and left coronary injection, demonstrating the patent Lima and patent stent in the LAD, patent native LADs applying the diagonal. Final FFR in the diagonal was good. So now in age 84, in 2020, he presented for a pulse generator replacement with pacemaker battery end of life, which was uneventful. So his current status at 85, was last seen in November 2020. He's been angina-free since that last intervention, which is 6 years. He's fully active, mows the lawn every weekend, excellent quality of life and normal LV, and very emotional and grateful for how he's been able to keep going for 29 years and looking forward to the future. So what we've seen is really the evolution of intervention from plain balloon angioplasty, native vessel drug-eluting stent, saphenous vein graft, drug-eluting stent, saphenous vein graft CTO, reverse cart, retrograde dissection reentry, aorta ostial CTO, wire-based integrated dissection reentry, IVUS physiology, drug-eluting balloons, pacing and ablation. And what did I learn from this case that spans my entire career? That dogma isn't always true. We need to individualize therapy. Sometimes these diagnoses can cause severe lifestyle limitation. And you can sometimes get a long durability out of treating a vein graft. As our field progresses, we are able to offer more patients. So initially, we could only open the vein graft. Later, we could then do CTO pre-CI. And I want to show that PCI is durable, contrary to many misconceptions, that this is a patient who had PCI over a long period with a durable long-term outcome, despite needing a couple of re-interventions. And that intervention does make a big difference to patients. Thanks.
Thank Farrell for this nice case. It's 12 items in the field. I remember the statement of my boss Spencer King that it's a beginning. It's the beginning of the story to have atherosclerosis. It's not just to have a catheter and do PCI or just doing CABG. You have given us illustration of how the history of atherosclerosis continue and how the science continue, and expertise is very important. And your patient is lucky to have such wonderful intervention cardiology at center like you and your colleagues, because you did everything with electrophysiology. Thank you. But my question to you, the problem every time is the diagonal for the pain, which is not sizable. Usually in some centers, these diagonal, they give them medical treatment and not going for intervention. How can you explain the amount of ischemia with the size of such a small artery?
So that's one of the messages. Obviously, this was not a life-threatening situation for this patient. It was a quality of life issue. And he was on beta blockers, calcium channel blockers, nitrates, maximal medical therapy, and continued to have terrible angina. So medical therapy had failed in this patient. And every time we opened, this patient is an incredibly reliable witness. Every time he complained, he had a blocked vessel. In between, he was perfectly well. So we knew exactly when there was a problem, and he responded well to therapy. He had very typical severe limiting angina, which sometimes you can get. You know, the chest pain is such a variable thing. That's something we don't really understand very well. Who gets chest? Some patients with terrible disease don't get chest pain at all. So I think that's just an interesting individual observation for patients that we have to be aware of.
Okay, any question from the panelists?
Just a comment, if I may. Farrell, I think that just to highlight a little bit more what you're saying, I think as interventionists, we have become obsessed, and perhaps rightly so, in demonstrating that the interventions that we do in chronic stable coronary artery disease make a prognostic impact on our patients. But in fact, here, I think what you've beautifully demonstrated in this patient is that symptom relief and quality of life is a legitimate goal for therapies. And beautifully highlighted by a man who has excellent quality of life after 30 years. And thank you for sharing the case. A wonderful demonstration that the only therapeutic outcome is not a prognostic intervention, but indeed the relief of a patient's symptoms or why they come to see us very often.
It basically also illustrates the length of your career already, Farrell. Sorry, but
Yeah, that's a bit of a sad admission, I'm afraid.
Thank you, Farrell,
You're
for
not
this
alone.
nice case.
You're not
Excuse
alone.
me if you have maybe a question about
Sure.
this case. It's I'm asking the question for all of you. Do you think that we can live with the occluded left main with distal cabbage? I think that I have a patient and I did not exactly, mainly the same to reopen the left main, because some patient when they have occluded left main with the distal cabbage, they have still ischemia, and you have to go to the left main and open it again, and then the patient is have the relief of ischemia. Do you have any cases of like this?
Actually,
Yes,
absolutely right. Well, I've come across many cases like that where you have severe distal left main stenosis, you open up and the patient remarkably feel better. I think the proximal vessel is also as important as distal vessel. And it does improve coronary revascularization, and that improves symptoms altogether. So yes, if patient is not, despite having bypass, still symptomatic, and you don't see any other target, then possibly that's the target to improve the symptoms.
But so I think it depends on the number of the proximal vessels. If a sizable diagonal or sizable OM, I think it's better to do the left main, maybe left main. But the problem, left main LAD or left main circumflex, this depending on the anatomy.
Yes.
Okay. Zank or Eric?
But Farrell, my one question to you about your case. I mean, it's excellent, and it just defines that this PCI versus medical therapy, optimizing medical therapy, improving quality of life. So you've clearly demonstrated that intervention does improve the patient's symptoms. My only question is whether you actually did any stress cardiac MRI scan at any point to see the infarctory territories areas to know which area will benefit from revascularization.
So the patient had normal LV function, and it was always a single problem, really. Okay, eventually there was a distal LAD, but clearly he had equivalence of single vessel disease, really, in terms of his cause for symptoms. So it was quite clear in our minds, the clinical decision making, that the diagonal was the problem. We did eventually treat the LAD when he later developed that stenosis in the LAD, but I think, so perhaps it was both at that time, but we didn't feel the need to go and do more diagnostic testing. We thought that our clinical and angiographic information was adequate.
Okay.
Well, during our angioplasty, we leave a lot of diagonal pinched after LAD PCI, and patient keeps coming back with ischemia. And I feel that the diagonal is actually quite a big culprit for ischemia ongoing angina symptoms. And we always leave it alone as a conservative management.
Yeah, I think we mustn't underplay diagonals just because they're called a diagonal. The label for the vessel doesn't mean it's not causing trouble. I think, we obviously have a hierarchy of vessels that are relatively more important than others, but any sizable vessel can cause symptoms in a patient.
I think that your case is a lesson for all intervention cardiology and cardiac surgeon that this patient is our patient, and the surgeon can face the patient only once in his life. And you are taking care of these patients for about more than 10, 12 years, taking care for the pains and the symptoms, the medical, even the electrophysiology, DDD, ablation. So this is very, very important to look, to be a friend your patient and see the quality of life of patients, if it's comply with the treatment or not, and then taking the best for the patient. Thank you very much. And then David, can you introduce the next speaker, Dr. Kamal?
Maybe you can. I don't have the program in front of me. Sorry.
Okay. I introduce now Kamal Kitera from United Kingdom. Is going to speak about one case, Catch Me If You Can. We know Kamal is one of the intervention cardiologists who had a book about complications, and I'm looking for this case.
Thank you, Mohammed. Thanks for the invite, and thanks for the Pafcic committee and Habib for having this opportunity to show. This is a case of mini series of Catch Me If You Can. I'm sure you all have seen this movie. So I'm going to just take you to part one of this mini web series, Catch me if you can. And this is the first patient is a 76-year-old female, background of COPD, hypertension, or reflux disease. And she's got one episode of central chest pain. Troponins were elevated from 350 and went up to 4,000. That's the ECG. Nothing remarkable apart from a bit of tachycardia. So catheter proceed. I'll show you this picture. This is the right radial approach, 6-French radial sheath. My SPR was doing this case. And you can see the loop in the arm, which is like a 360 degree. So he decided he couldn't put the 035 wire, so he decided to put a BMW wire and see if he can go up. And see the next picture, how aggressive this catheter is. And that snapped the wire straight away. So that's the BMW wire being snapped by this diagnostic catheter. So the next thing is you can see how the BMW wire is right up to the subclavian. So the next option was, can we catch it? So these cases actually, they look quite straightforward that you're going to snare it or you're going to take it out. But obviously these complications should not happen at first place. Yeah. So this is the most important part. These cases, I'm going to show it in the next few minutes, but they take about 1 to 2 hours to tackle with these kind of cases. So next, this is the goose snare device, and we capture the end of the BMW wire. And I think everybody should get familiar with these devices. We have one or the other way we may line up every one or two cases per year. So that was caught and rechecked the anatomy, and everything was clear. So from my point of view, learning point from this case is, you can use the hydrophilic wire if you have a brachial loop 0.034 wire. You can use a coronary wire as well. Hydrophilic coating guide cath do help, and they do straighten the brachial loop with 5 and 6 French catheter. But over the period of number of years, I've seen more and more complications happening when you see a 360 degree loop. And when I see them, then I tend to stop my case rather than maneuvering like this. And even if you maneuver with a balloon assisted technique, either you can snap it or you can cause tortuosity on this catheter. It can completely get kinked, and the loop may not just solve the problem as well. It may not straighten up at all. So I personally tend to stop when I see 360 degree bends like this. So balloon assist technique is definitely a good thing to do when you see a significant coronary spasm, and it does work when you put a balloon, take a 2.5 millimeter balloon, keep half in the guide cath and half out and inflate it up to 10 to 12 atmosphere, and then travel up on the coronary wire. So it does work, and this is the demonstrated technique, but I will not do it in 360 degree loops. You can snap the wire or fracture the balloon, or you can kink the guide cath completely. So another case where you can catch, this is 53-year-old chap, history of DVTs on rivaroxaban, exertional chest pain, troponins were mildly elevated, but he gave a quite good history of angina of ongoing pain. So he underwent catheter proceed, right radial artery, 6 French radial sheath, diagnostic 5 French GR4 catheter, guide wire was screened. And this is when I went to the shoulder, and I saw what's going on here. Why there are 2 wires. One is the O3 wire, and one is the second wire. So I looked at the packaging and everything, and I said, where is the wire? And this was actually the radius sheath wire being left by the SPR in the sheath itself, which traveled up when I was pushing the diagnostic catheter, and that took it all the way up. And now we got this problem there that we have this radial sheath introducer wire inside the arm. So tried to manage a bit of snare, pulling it down a bit, but obviously proved quite difficult because the wire was below the shoulder. It could not be snared from the top end, and you couldn't push it up. So I did the reverse, this balloon tracking, where the tip of the wire came into the sheath, pushed the sheath up, and then reversed it and trapped the balloon with the balloon and pulled the whole thing out. So first with the snare, pulled the wire down a bit. Then when it came near to your sheath, and then I trapped it and pulled it back all the way. This is another case where you have a patient with a TIC catheter, and my SPR kept on rotating it. due to subclavian tortuosity. And you can see there's a significant link when I could not engage into the right coronary artery. And I screened the whole arm and I could see there was a significant kink. And this was a virtual breaking point. So you could not cross any 034 wire or even a 0.01 wire. So even the opposite end of the wire became proved difficult. And it looked like as if it's just going to break off. So what I did was come to the, put a sheath in the femoral and snared the top end of this diagnostic catheter. While you're pulling it, kept on screening the arm at the same point. So you can see while you're pulling it down, you are rotating. So it's like a two people's job. You want one interventionist to pull it, and the second interventionist to do anti-clockwise on this catheter. And once it was anti-clockwise done, then put a 035 wire and was able to pull back the whole catheter down. So this is another case where you have the top end is completely rather than the distal end. The top end is due to subclavian tortuosity and has completely kinked at the top end. Again, it was difficult to maneuver into it. So the best thing to do is never pull back. If you pull back, then you will be leading to a disaster. It's better to put it more in the aorta, ascending or descending, and try to manipulate it there. I have a second sheath straight away in. So 6-man sheath was put, but I couldn't put any, tried passing this, navigate the 035 wire or coronary wire, but will not cross the loop. So again, this is a goose snare device, and try to undo this reef knot. And while you are pulling it down, making it straightening it up, and after that, I was able to put the 035 wire when it was straightened down, and then it came out through the radial route itself. So yes, my learning points from these 3 to 4 cases is that try to avoid any aggressive rotation of the catheter. These cases look simple that you have pulled it out, but actually they are nightmares to deal with at the time, and it can take up to a couple of hours. Get the team. Always ask your colleagues to come and join you. When you want to undo it, go for anti-clockwise direction, because most of the time you have manipulated it clockwise direction and you keep on doing it. Try advancing the standard 035 wire or opposite end of the wire to see whether you can cross through the knot. Manipulate always these catheters in the aorta, but never pull back. Say the patient, my personal thing is I always give all my patients do get midazolam on these patients. Do get familiar with the devices, have it on the shelf and always play around with it, because on the day when you need it, you should know how to operate upon these devices. So to conclude, I will say, yes, we can catch, and but you cannot certainly avoid these complications by being more vigilant about the subclavian tortuosity, or when you're manipulating and nothing is advancing forward, and you must stop and screen through the arm and screen through the chest. So learn to solve these complications, call for help earlier, call for your colleagues, call for intervention radiologists, and learn this in a methodical approach. So this is another way of learning things. You can have this book and read through. There are lots of complications being written more or less, I think, throughout the coronary cases, which can be helpful for junior doctors and consultants. Thank you very much.
Thank you, Kamal. Before opening this, thank you very much for this. The radial. For the radial, some speculation of some of my colleagues that the air condition can produce spasm to the artery. Do you believe in this? I don't believe, but they believe, and they have to stop the air condition because the spasm of the artery.
Yes, patient do feel cold, as you say. So yeah. All my patients, they not only get draped up, you can give them a blanket as well, because they're coming from a different temperature all the way inside. It's different temperature altogether. I give all my patients midazolam, regardless of what they think. It just reduces the risk of coronary spasm. I give them the cocktail, give them verapamil and nitrates. I have also started screening all my patients with the radial. Take a diagnostic image, and then it tells you the whole anatomy, whether there is a loop, rather than navigating blindly, and then you find out later on why the wire is not going. What happens in these cases, your nurses or the doctors, they try to push it forward, and you can perforate.
When you have a resistant spasm in the radial or the radial artery,
spasm is very common. You can easily avoid it.
Yeah. What's your solution?
The solution is I'll give all my patients do get intra-arterial nitrates and verapamil. I always give my patients midazolam. So they all get it, and I always screen the arm, take a diagnostic injection of the radial, and then I know whether there's any loop, what's the vessel size. So it gives me a lot of anatomical information before I advance the wire.
Any questions from Eric, David, Ben,
Thank you, Kemal, for these cases. So I know that every cat lab should have a snare, maybe two type of snare, one loop or three loops. But sometimes we don't have. So what do you use when you have not a snare in the cat lab? I know that some people describe with two wires.
Yeah,
You can
different
make
word
it by
altogether. I
yourself.
think you can tap with the different multiple wires as well and see whether you can entangle them and try to pull it through that. That's another choice.
Can I
So
make a
You
comment?
can make your own homemade snares. You can have a stiff wire and bend it and see if you can bend it at the end. I've seen a couple of cases being performed in Africa with these homemade snares and can be used. Well, we are fortunate to live in a different part of the world, but we have snares available, different sizes on the shelf. But yes, it is very important to learn how to make a snare.
Okay. Eric? Okay. Yeah.
You're on mute, Eric.
Yeah, mute.
Eric, you're on mute.
Mute.
Sorry, that's why I was frustrated because nobody talked to me. That's why I was mute. I don't know. Sorry, no, the homemade snare technique is the first described by Satoru Shimizu. You use the modern version is to use a guide extension, put a wire on top of your balloon, make a bend, then introduce it into the guide extension, and then you can basically create your loop as long as you want. I've never done it, but that's what Satoru has described in various settings. So it's something to consider.
Just
Yeah,
Kamal, just a comment. I was pleased to hear your conclusion on radial loops because I think in the beginning of radial intervention, we were all very keen to prove that we could do every single patient radially. And I've reached the same conclusion as you have that when a patient's got a 360-degree loop, I've done a couple of patients like that without complication, but a number of them have had persistent pain throughout the procedure. And so for me, I don't try to straighten them out anymore. I've decided that femoral angiography is a very safe and good option. And so I must say no heroics from the radial for me. 99% of cases are radial, but the loops are done femorally.
Dave,
I'll also say that 10 to 20% of it, if you find a loop in the right arm, you're bound to get a loop in the other arm. So 20% of cases can be bilateral loops. So there's no point running from one arm to the other arm. Also just go for the femoral approach. I know we all take pride in crossing these loops and we'll show off and right, we can go navigate and it's easy. But I tell you, there will be one case which will become a disaster.
You know, I did an angio in a friend. Can you imagine who had a loop? And it was horrible. He was suffering like hell and he started to swear. So I can tell you at this stage, stop.
The loops carry that risk that sometimes the accessory radial, I've seen an accessory radial sheared off from straightening a loop, which has made me very, very cautious for straightening these out. So we can, but I don't do it anymore.
Okay.
We need to move on, I think, yeah.
Is Antonio Colombo with us? Antonio?
Hi,
Yeah.
Mohammed. I'm here. Can you see me?
Yeah, I see you, Antonio.
Thank you. And, I was listening. I totally agree. No reason to push the radial. If you have a femoral, switch to femoral. We did femoral for 30 years more.
Mm-hmm. I think that the femoral expert is important. And also, both the radialists, I remember one live case when you have, with your fellows have difficulty, you said that he doesn't know how to do the femoral, he do only the radial. So you have to do femoral and radial because sometimes you can make it, but
you know, and now the femoral with visualization, with closure device, etc., is much better than in the past.
Okay. Let's start. I have to introduce my colleague, my friend, Antonio. Thank you, Antonio, that you accept to get to Pafcic. You have two cases, I think. One is called to correct diagnosis before treatment, and the second is chronic perforation. So let's start with the first one.
Okay, I start with the first one. Let me share the screen. Can you see me?
Yes, we see you.
Okay.
Okay, go ahead.
So we are dealing with a 78-year-old lady scheduled for a AAA percutaneous graft. Patient undergoes elective coronary angiogram, right radial, for history of atypical chest pain. You may really wonder about how appropriate this indication. I think the operator wanted also to check the neck, but all this information can be obtained by angio-CT. Risk factor, hypertension. So the procedure is performed from the right radial. This is the first injection. Patient is totally asymptomatic. ECG is totally normal. You get a second injection. Patient is still totally asymptomatic. Blood pressure is 160 over 80. No ECG changes.
Can we stop and discuss with you?
Yes.
Yeah.
What would you do at this time? Let me stop a second.
Yeah. I think
The
it's an
patient is fine. Everybody's fine except the operator.
I think this is the first assumption is that an air embolism or maybe embolic depress from the casters down. But first, usually we have two vessels, usually air embolism. I don't know the opinion of the other panelists.
I think there are two problems, Mohammed. One I see is
but
that
you know,
air embolism.
let me, I mean, if it's air embolism, why is the patient is fine, no ECG changes, no chest pain?
This is a dissection,
This
actually.
is dissection, you see.
And also seen dissection here. Dissection. In these pictures, left main dissection.
Yeah, but why the patient is fine, is asymptomatic? That's my question.
He's waiting to be symptomatic.
Probably that we are not in the true lumen with the catheter, so the true lumen is working good.
Yeah, I think you made the right diagnosis. You are in the false lumen with the catheter. The true lumen is perfusing the vessels well, and that's the reason why the patient is asymptomatic.
Antonio, there is a suggestion from Sigwas here. The catheter is too small and makes dissection. This is
But what would you do at this point?
I put two wires, wire LED, wire thing, and then look after, and then give if there is bradycardia, atropine to the patient, and then look again to see that.
But why the patient is asymptomatic?
I think first of all, we have to change the guiding.
Integrated product for the patient maybe is asymptomatic.
Okay, let me continue a second. No ECG.
Change the guiding, maybe it's a better choice.
So the right corner is visualized and is normal, and there are no collaterals to the LED. What do? You stop everything? Patient is fine?
No. I came back to the artery. I put a guiding catheter in the LED, see what's going, because I'll be ready if you are looking for dissection or just putting wires. Okay.
So at this point, a guiding catheter was inserted and the floppy guide wire advancing the LED.
How do we know this is not in the false lumen?
Exactly.
I
think again, the answer is let me go back, is here. As a matter of fact, you see better here. Everything is false lumen, what you see, but if you look late, you see that the LED comes in with good flow.
Yes.
So at the ostium of the left main, you basically have double lumen. one false lumen is the one that you see, and one true lumen is the one that is perfusing the vessels. And that's the patient, the reason why the patient is asymptomatic. So this is a correct diagnosis to be made.
Yeah.
So if you have to go maybe with two wires, one in the false lumen and one in the true lumen, which was not correctly done. The wire went into the false lumen. The artery is most probably healthy, so very easy to be dissected. And the balloon was inflated. It's amazing.
Yeah.
The true lumen now is communicating with the false lumen, and you have perfusion of the diagonal and some septals. So this tells you that frequently false lumen communicate with true lumen, and the patient is still asymptomatic.
You think that this patient has spontaneous dissection?
No, dissection is created by the diagnostic catheter. The first injection created the dissection.
Iatrogenic dissection, and now it has extended further to the
Yeah.
middle.
Yeah.
But these are, how do you make a dissection worse if it's like this? The way to make the dissection very bad is to place a stent. So a stent is deployed, and the stent is deployed in the false lumen, which basically occludes every connection between the false lumen and the true lumen. So the false lumen really becomes a true false lumen because you close the true lumen. That was done. At this patient, at this time, the patient has chest pain and there is a significant ST elevation. So basically, really you see all the steps. Iatrogenic complication, wrong diagnosis, retrospectively, a short stent at the ostium of the left main would have been sufficient to close the entry of the false lumen. But here the stent was placed in the wrong place.
So he died.
No. After these, even another mistake, a second stent was placed more distally. But then, luckily, were able to break into the diagonal and re-establish flow in the diagonal. So at this point, the hemodynamic improved. And then no more stents, just balloon dilatation of the diagonal. And luckily you see some septals, most probably communicating. And then going through the false lumen into the true lumen, like a star technique, it was re-established some flow in the circumflex. Not ideal, but at least better than nothing. This is all extensive dissections with communications between, you see also, and this is the final result. Patient had several complications, but stayed in the hospital 2 months, but finally she was discharged. 3 days follow-up. Some balloon pump was removed at the end of the procedure due to leg ischemia. The patient suffered distal leg embolization, which required multiple endovascular procedure with the need to perform a transmetatarsal amputation. Patient developed renal respiratory failure, required prolonged intubation. Patient became fully ambulatory and was discharged at home 4 months after the procedure. At 3 years follow-up, patient is stable, alive, self-sufficient, and the AAA aneurysm is still there. Thank you
Great.
for your attention.
Great case. Any questions from the panelists? Eric?
Yes, I suppose before you stand in this left wing LAD, you would use IVUS to examine the wire the position. So that before you get back this situation, I will use IVUS to examine the wire the true lumen of first lumen, because the first lumen is so large.
Do you have some tricks to tell us how to go to the right lumen without?
Well, I think to go in the right lumen would have been easy. Sorry, someone. To go into the true lumen would have been easy if you knew if you knew that there is a true lumen. We did not understand that there was a true lumen, so that was a problem.
I think one of the view you could see the top end, that there was a shelf which looked like a true lumen intersection almost splitting in the middle of the left main. IVUS guided PCI could have been the answer to see where your true lumen and false lumen is, and also the wiring the circumflex from beginning as well, because that was another one would have helped securing some blood flow into the coronary artery. And obviously, as Antonia said, securing the left main right in the beginning by short stent and then deal with the rest.
You know, most probably, you know, retrospectively, even if you did nothing, patient would have been okay, because the flow would have closed the false lumen and nothing would have happened.
So do you think, again, in retrospective, if we don't know that this is the false lumen, you put another wire?
Oh yeah, I think first the key was to make the right diagnosis, understand that the reason why the patient was asymptomatic was that there was good perfusion.
Okay. Okay, let's go for the second case.
Okay.
Mohammed?
Habib? Okay.
Yes.
Antonio, stop the Habib,
Yes.
we are in. Did you
Yes,
finish?
You finished, yes. We just would like to show you how we finished the case. It was a very challenging one. So I don't know if you see the angio, the coronary angio.
No, so we see you only.
Okay, can you show the coronary angio, please? So it was a quite difficult case, mainly because of the backup of the guiding. We used an extra backup. Do you see it now, Mohammed?
Yes.
You see it, okay. You see that septal branch that is having a 90-degree angle takeoff from the LAD. So it was quite difficult to go in there. We used a run-through wire, and then it didn't go. We used the whisper extra support, and you see we go in, but we cannot navigate the wire distal to that septal branch. And then we had to change actually the guiding to an on-Platz left in order to be able to do that, which is not quite usual, according to Hubert Seguis, who was proctoring us remotely for this procedure. But it was the only way for us to have a stable guiding and go into that septal branch. And then we went with the balloon. Can you go further, please? And we jumped out after that with the balloon inside. So it was quite, okay, you see the balloon. It was a 2 millimeter by 6 millimeter diameter, 6 millimeter length. Next, please, next. Okay, it was there, and then we did inject some contrast. I would not show you everything because many of you are familiar with the technique. We did inject contrast inside just to locate the distribution of that septal branch, and then we inject 2 cc of ethanol, 95 degrees, and then we did inject. Go, please. So we had a 40 millimeter mean gradient in the beginning, and we will show you. Okay, you see this is the injection distally, just to make sure that we are in the right branch and that there is no flow going back into the LAD. Next, please. And next, just to show you the final result. Next, again, next. It should be this one where you can see the LED widely open and there is no saturation anymore. The gradient went from 40 to 0. It was, you know, it was a very nice result after 2 hours or more than 2 hours of work on this procedure. Thank you very much. And then you can keep going with the program. We'll
Thank
join
you.
you. Thank you.
Okay, Antonio, let's go for the case, your case.
Okay, I go with the second case. Share screen.
Image.
Okay, can you see the slide?
Yes, we see.
Huh?
Yes, we see.
Okay. Oh, this is a 94-year-old gentleman, non-ST elevation MI, had a serum creatinine of 2.3. This is the first injection. He never had an angiogram in his life, 94 years old. So I think no reason to do extensive diagnosis. You see one tight lesion in the middle AD and one tight lesion in the circumflex. Right corner is occluded. So despite the renal function low, we were able to use very little contrast, only 50 cc. We treated the LAD with one stent and the circumflex with one stent following pre-dilatation. Procedure was, I must say, quite straightforward. We had to use a pilot 50 wire to go into the calcific circumflex because it was very difficult. If something happened, I don't know why the wire was advanced so distally with a big loop. You should never do this kind of maneuver. I don't know why it was done. And now you see some consequences of this event. There is a distal perforation from the wire and a big time pericardial effusion. So considering the age of the patient, the renal function, etc., we elected to take the most quick and straightforward approach, which retrospectively was wrong. We did a balloon occlusion, we checked that there was no bleeding, and then we put a short cover stent to exclude the origin of the obtuse marginal branch feeding the perforation. The problem is that 3 hours later, patient developed new tamponade requiring emergency pericardiocentesis, bleeding. The stent is in, the cover stent excludes the obtuse margin, but things are not fine. Maybe I can stop a few seconds for some discussion.
Can you bring us to the site of perforation again, just to the angiogram before cover stent? Is it wrong? Because
okay, here, this is the wire, distal circumflex. Did you see some dye floating around?
3 perforation.
And this is before the perforation seems more or less in this area. So we put a stent here to exclude one margin. This after the stent. So we excluded the top OM.
But there is another OM again. It was
Yeah.
two OMs.
I think that this is a problem of the distal perforation in the big artery like this. And I think in these cases, the coverage stent doesn't resolve the problem because we have the retrograde filling and this obtuse margin that is aliments the pericardial effusion. Even if you put like this coverage stent on the circ, the obtuse margin will be filled by the left system again, and we have another fusion in the pericardium. For this case, I think the better choice is to embolize the distal part of the marginal. I don't know if you.
Absolutely correct. Absolutely correct. I think this is congratulations. This is the right way to deal. When you have these distal perforations, you have to go distal and embolize distally. Do not close the feeding vessel, because the distal perforation will be supplied by collaterals, especially in these patients with extensive collateral builds during years of chronic ischemia. And that's what happened here. By doing the cover stent, we did two things wrong. One, we did not close the collaterals, and the collaterals, we gave problems to do embolization distally, because now it's difficult to do that. So
I think the operator thought that he has caused mid-vessel perforation, and that's why I put the cover stent. If he had thought about that as a distal perforation, probably would have dealt it differently.
Yeah, but also, the problem of the renal failure made the operator take the quicker solution. Distal would require more dye to cannulate the branches, etc. So here is looking for the leak. Patient is still okay. We have pericardial drainage and reinfusing the blood from the pericardium into a vein. Here we did very selective injections, try to localize. We took a guideliner to do selective injection to localize the bleeding. We inflated the balloon. So you still, even with the balloon inflated in the OM, maybe it's coming from the LAD, the distal LAD. You see that there is some dye that comes from the LAD into that area. Here with the balloon inflated more proximally, you see that the LED is feeding the area, but also a selective injection in a distal branch gives some flow. So at this point we went more distally, here the LED again, and we decided to embolize a very, very distal LED with coils.
Antonio, if we don't have coils,
then you can take fat.
Fat from the thigh.
Yeah, you can take some fat. We also embolized the distal part of the OM, but still there was bleeding. Distal LED embolized, distal OM embolized, another small branch is embolized, but nothing. Patient died 8 hours later, kept on having pericardial effusion and never stopped, despite we gave protamine, the stent had a clot, but we reopened with heparin, so the coronary circulation was okay, but the pericardial effusion kept being formed by collaterals. So as you said, I don't know who said the right diagnosis, but congratulations. When you have a distal perforation, do not occlude the vessel supplying the perforation. Look where the perforation is very distally and selectively embolize coils, fat, beads, whatever you have, the very distal vessel where the perforation took place. And this is the learning lesson. Thank you for your attention.
Thank you, Antonio. I think you did a great for two important cases. One regarding the correct diagnosis, and we learned a lot about the true human, false human. The second regarding the distal perforation. And actually, I said that if you don't, sometimes some centers, we don't have exactly how to do the coil. What the coils is, there are different coils. How can we differentiate, or which coil you prefer, which is easier for the cardiologist, not the pediatric cardiologist, because sometimes they bring.
I think any small coil, detached, not sophisticated coil, coils that are simple detachable coils that neuroradiologists use for the brain, not. They are electric detachable coil. You don't need this sophisticated coil. Just simple detachable coils are fine.
May I make a comment on coils?
Yes, Eric.
Coils are basically not intended to be used in the distal part of the coronaries, and they really don't unfold always well. So I stopped using coils, and now I use the microvascular plug from Medtronic. It's a very small kind of parachute that I also used to close fistulae. Pulmonary coronary, and it's very, very simple to use. It's basically an umbrella, like a parachute, opposite parachute, that is screwed into a delivery system. It goes in a very small microcatheter, 021, 018 even, and you can get it everywhere. So
what is the name?
The microvascular plug of Medtronic.
Microvascular plug.
Medtronic. I will send it on the group. It's fantastic.
Can you send us? This is called microvascular plug from Medtronic. Okay.
I will go on the internet. I will find it for you.
Okay.
So in Tunisia we have a problem to have coils, so we use blood clot most of the time, and even with I know it's not as effective as the coils, but we use what we have. We use blood into over the wire balloon just to embolize. If the microcatheter are the over the wire balloon are cheaper than the microcatheter, so we use over the wire balloon with the filling with the blood at the most time.
I can show you on the screen the microvascular plug here.
Okay.
You see this?
Okay.
This is it. You see that?
Yeah.
Yes.
And it can go in 2 millimeter vessels. So it's really nice. And you see, this is the screw. Really nice thing. It's not used in the coronary. I think I'm maybe the only one who's using it in the coronaries. And everywhere I go, I make publicity for it because it's really great.
Okay.
You can use it in bigger sizes for big fistulae, coronary, pulmonary.
I think it's expensive, right?
Oh, I don't know.
I just use the coil is very cheap, and Boston Scientific coil is cheap as well and very effective. It's just a few minutes to seal the embolizer, this kind of a vessel. Very easy.
This question
to deliver.
Okay, we have 1 month ago a case like this with my colleagues. We search for a coil, we don't find it, we ask a company to bring a coil, and this is new for us. So we spend sometimes looking to internet and looking how to do it, and finally put fat embolization, and patient survive. So we have to do. You have to put in your core lab some forms of coils which you know. As Eric said that I will ask Medtronic, and I will call you to help me, please. And then we can, as a cover stent, so we should have a cover stent, and we should have also coils. As Antonio said, with the conclusion, distal is coils, peripheral or proximal mid, we could use a cover. Antonio, the question to you, I heard from you before, if you have a perforation in the artery, which is not distal, you put a cover stent, and sometimes you drag the routing stent inside the cover stent. Can you explain to me your thoughts about this?
We used to do it in the past. I don't think it's necessary.
It's not now.
I would not advise to do that.
Okay, forget it. Huh?
Forget it.
Okay. Thank you, Antonio. Can you join us for the next cases if you have time, please?
Yeah. I stay for another half hour. No problem.
Okay. Let's go. Horace Siebert with us.
Yeah, I'm here.
Okay, Horace. Hello, Horace. Thank you very much. I know that you are expert in paravertebral leak, but I don't think it's for expert paravertebral leak has complication. But okay, this memorable paravertebral leak closure.
Yeah, it's usually a very safe procedure, but I managed to create. So this is the case history. It's a 69-year-old male patient, mitral valve replacement in August 2009, paravalvular leak diagnosed immediately after valve replacement, then increasing pulmonary hypertension and shortness of breath, getting more severe over time. And this is the 3D echo, and you can see a leak, which is, let me show this right here, which has a diameter of 15 by 10 millimeters. And the question is how to approach this leak. And if you like, you can comment now. Eric has gone, right? Is anybody else doing lots of paravalvular leaks? How would you approach this one here?
Farrell with us. Dr. Farrell.
Are you still there?
Yes, I'm here. So, yeah, I think this I would approach from a transeptal approach using Agilis catheter cross.
Yeah, this is a good idea, but usually I do the
Transeptal.
other way. Yeah, sorry.
Transeptal, get a wire in the LV, doing grasp the wire from the arterial segment, so have a continuous rail, and then put a big sheet into the vein, and deploy multiple EV plug. Most probably, if you have the tree, is the best. You have to orient, but I think we'll always leave the wire like a tramway, and most probably 2 or 3 plugs deployed sequentially, and then you release all the 3 together at the end.
Yeah, that was my approach initially years ago, to go transeptal. I should have done this here this way, but more recently I changed my strategy. So in most paravalvular leaks, I try retrograde first. That means I come from the aorta and go through the LV, and then cross and advance the sheath into the left atrium. But you will see your approach is would have been probably better here in this case. So let me just move on. So I choose the femoral artery as axis. I did retrograde probing of the leak via the left ventricle into the left atrium, and then the plan was to do retrograde device implantation. And this is retrograde probing. You can see the wire is across the leak. I used the JR4 diagnostic 5 French catheter and the Terumo angled glide wire 35. And then I had problem number 1, and you may be able to see what the problem is here. Antonio or anybody else, what is the problem here? I can't hear you. Are you muted?
Can I see again so the wire?
The wire is here.
Yeah, the wire looks okay.
Mm.
But is there a thrombus there in the?
No.
No.
But the valve looks so. But the wire is not irritating the valve.
The wire or the catheter, I'm not sure, but you see ventricular tachycardia happened. Look at the EKG.
Yeah.
So this was problem number one. Obviously not a very serious one. I just had to reposition the catheter or the sheath and then it stopped. But it's something you should pay attention when you do paravalvular leak, as with any other procedure, this can occur. I think I had a total of 8 problems here, so we have to move to the next one, I think, because we are running late. Problem number 2 was friction, and that is something, those of you who don't do paravalvular closure, that's something which happens very often. So that is due to the calcium at the annulus, it's due to the structure of the valve, which is in the way. So it does not really depend upon the size of the leak. I mean, obviously, when you have a very big leak, then friction is not so often, but it can occur even with leaks of that diameter here. So it was not possible to advance the long sheath through the leak.
Yeah, that's the reason why to making like a tramway continuous, it really helps.
Mm-hmm. That means an arteriovenous loop.
Yeah.
Then going, at this stage, I didn't do the transeptal yet. So I would have to do transeptal, snare the wire, and then pull from the other side. That's a good option, yeah. Any other suggestions?
Yeah, so you mentioned balloon assistance. I think that would be an option.
Yeah, that's what I also tried before all this. Sometimes I had the experience that the stiffer wire works better, and sometimes a softer wire works better. So I exchange for the other alternative, whatever I started with, I go to the other option. And then sometimes a guiding catheter helps. For example, a IMA guiding catheter or right coronary guiding catheter, because you can rotate it and get through the hole by just changing the rotation. And what sometimes helps is a hydrophilic sheath. But I must say, this is something I almost always use in these days. So the Cook sheath, for example, the Cook shuttle sheath, helps to overcome this type of friction. Those of you who have seen my presentation yesterday about general tips, I used in this case what I mentioned yesterday. It's the balloon-assisted technique, and it works like inflate the balloon distal, if you can bring it across, of course. Inflate the balloon distal of the leak, and then pull it back into the leak, and at the same time advance the sheath to get over that problem. That's a technique which I also use for other procedures. For example, in fenestrated and branched endografting, that's something which is quite often used, where you also have the problem that you have friction when you go through the holes of the endograft. And then if you are able to advance the balloon, that centers the catheter, and then you can advance the catheter or the sheath into the defect. Very quickly, those of you who have attended the session yesterday have seen this. So you got stuck somewhere at the valve or at the calcium, then you insert a balloon, you pull back the balloon into the leak, and then you can advance the sheath. So then we had problem number 3, and that was something which can always happen when you are working in the low pressure chambers of the heart, that is air embolism. It was during the introduction of the long sheath into the left atrium. And so the patient suffered from ST elevation and symptoms of cerebral ischemia. Many of you have seen this problem before in other procedures, probably. I'm assuming that. So what do you do then when you have this situation? So patient has ST elevation and symptoms, a kind of dizziness or sometimes hemiplegia or is unconscious. What to do now?
Just give 100% oxygen and wait.
Mm-hmm. Yeah, usually it disappears. Although there had been patients dying from that. There was years ago a patient here in Germany, not in our center, she died from massive air embolism. So it can be really dangerous. So oxygen is certainly a good way to do. This patient fortunately had spontaneous remission and just waited a couple of minutes, and then everything went away. Which brings us to the implantation. At that time, it's a couple of years ago, we often used the PDA, the duct occluder, or the old AD01 is that, the old duct occluder, which has the advantage that the rim here is very small, so it's a very safe device for parabolic closure. The disadvantage of that type of occluders is that it takes longer until it gets covered, so there is some risk of hemolysis which can occur. So this is a 7 French Cook shuttle sheath, and you see the device is now pushed through, and it's opening here on the LA side. And then obviously I pulled the sheath back, and you see here it's still connected to the catheter, to the delivery system. The LA disc is open, and it's close to the valve, but it seems to be safe. And again, the advantage of this device is on the other side, there is no rim. So it's actually a good design for parabolic closure. And then I opened the proximal LV part, which is seen right here. And there was a small residual shunt here. You see this here? But not, we thought not important. So the question is, should I release it now? Antonio, should I release? Or Farrell, should I release?
Well, I always worry about this when you go from the ventricular side, your disc is on the low pressure side, and you don't have a disc on the high pressure side. So So you have the higher embolic risk with this device.
Yeah, that's a very good point. But when you look here, you can clearly see that this device is compressed. So I felt very confident that this device would definitely not embolize. Also, I did a push test and a tug test as well, but push test is more important here. So I had no concern.
I think the concern that has been raised is very appropriate. The disc on the low pressure chamber is not ideal.
Yeah. Again, so it's well taken, but I had not that concern. Do you have any other concerns here? Should I release it, or would you retrieve it? Or not use from the beginning? That's a different story then. At this stage, you are coming in. I'm your fellow. Antonio, look at this.
I would have used the double disc device, something with. I am afraid that. But I think at this point looks okay, so you have to release it. But
yeah. So again,
I know what happened.
I'm your fellow. I'm in the middle of the procedure. You step into the lab. I say, Antonio, should I pull it back because it's wrong design for this indication, or should I release it? What would you recommend then? You are the boss, and you are responsible for this patient because you are the hospital.
Looks okay. Just release it. Release it.
So you said release it, right?
Yeah.
I released it.
You released it completely.
I released it. So fortunately, you are responsible because I asked you before I released it whether I should do it or not. So I did it. And so what should I do now?
Well, I think you should do a transeptal.
Maybe you have to do a transeptal.
I helped you with that because initially I said the transeptal would have been a good idea. So it was easy for you to figure out that I should at least now do a transeptal, right? So this is the thing, how it works around. I don't know whether this is transmitted via the internet. Can you see the device?
Yes.
Floating around here?
Okay.
Yeah.
A transeptal, but to do what?
But at least to close the device, to close the leak.
Yeah.
I don't know if you can grab the device. I don't know.
Should I try it or should I just leave it there? Would that be an option?
I think I would try.
Yeah, okay.
I think you must get it, because if it goes through the valve, then it may go into the aorta, into the brain anyway. So if this thing can pass through the valve, I think it's small enough. So I think the other thing, what I found is like a safari wire or a wire that coils up can sometimes stabilize this thing in the atrium. And then you can go parallel and try and catch it. Not that we've had to do it very much, but I've had a case with a watchman that came loose. It's obviously a lot bigger, but a safari wire was able to stop it from bouncing around the atrium, and we were able to snare it.
Interesting. So I did the transeptal puncture here. I used an 8 French, and this is important here. I used an 8 French transeptal sheath via an 18 French venous sheath in the groin, and I will explain later why I did that. So there.
Horst is frozen, right?
Yeah.
We cannot hear you, Horst. Horst?
So, Farrell, is there any tips how you can fish that that occluder in the left atrium? It's moving too fast, and I don't think that's, if you have the chance of having similar cases and being able to fish that one.
Yeah,
moving too much.
You've got to get lucky to catch it, but you need to take something to stop it from bouncing around. So a big snare can sometimes, a big multi-snare can sometimes gather it, or a safari wire, coiled up wire. I've had experience with a watchman being stabilized like that. But I think you've got to be I've seen a Twitter image of someone catching one of these in mid-flight in the atrium with a snare. I've seen one recently on Twitter.
Yeah, I used I had the 40 millimeter, the German company, the Astor snare. So I was able to capture it. And now maybe you see what happened now. Can you see what happened now?
So
it's folding over the sheath.
It is not. It's not possible to pull it back into the sheath, right?
Yeah.
And that is something which happens quite often when you fish something. Actually, you see it pretty clear here. So the distal end of the sheath is folded inwards.
Yeah.
And that is something you should always be aware when you capture something. It's independent from the size of the sheath. It can happen in big sheath as well. This was an 8 French sheath. So what to do now?
But now you have a bigger sheet in the groin. So can you try to change a sheet and put a bigger sheet?
Yeah, but how to change? I mean, this is I have it now on the snare. So
I think it will pull. It will probably pull through the atrium, the interatrial septum. Perhaps it may damage the interatrial septum, but you may be able to just pull it through and then put a parallel wire in the femoral vein to secure access and pull everything out through the femoral vein.
Yeah, that's what I did. So I pulled pretty strong here. And then I was able to just pull it down. And here comes the advantage of the bigger sheath, which was in place. So I could then pull it together with the 8 French sheath into the 18 French sheath. So it was out now. So then I did what you suggested from the very beginning, to do an antegrade probing of the defect. This was again with JR4 and angled glide wire. And then I created the kind of loop which goes to the aorta. And this was an Amplatz extra stiff wire now. And then I used a device which you like more, which is the VSD occluder, which has rims here on both sides. I could have used the PDA occluder, of course, but I want to be sure that this never should be embolized again. So that's why I use this device here. And this is the regular Amplatzer sheath, which comes with the device. I open it in the on the ventricular side of the leak, and then did a tuck test, pull test, and tuck test. And then I checked. What is very important, as you all know, is to check the position of the leaflets to make sure that this device is not in contact with the valve leaflets. And I think the best way to do this is by angiography, by fluoroscopy. And you can see the problem.
Yeah.
Oh, you don't see it. You see here that actually both leaflets are here. It looks like, but here you see that both leaflets are moving freely, so that's okay. But then you see on TEE that one of the leaflets, a couple of seconds later, did not move. So there was leaflet interference. Here's the device.
Yeah, but that's the reason why I think it's better to use a vascular plug and more than one. Because if you use 2 or 3 small ones, especially with mechanical valves, is less likely to interfere. With biological valve, you have less of a problem.
I totally agree.
Horst, maybe if you switch off your video, you'll transmit better, because sometimes the video is what causes the signal to drop.
He must be somewhere in a place where poor internet connection.
I'm sorry.
He's back.
I'm sorry. My internet is coming and going. Can you hear me now again?
Yes.
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 So I didn't hear your answer, but I'm assuming that you said I should reposition the device. So I pulled it back partially into the sheath and pulled stronger and found a different position here. Again, tuck test and control of position of the device. And just put this away. So this is the release of the device. You can see I'm clearly away from the leaflets now, so that looks pretty good. But then we had problem number 7, which was actually on the next day on the regular ward, and the patient suddenly collapsed and underwent CPR, which was successful. EKG showed nothing than sinus tachycardia and no signs of acute MI. So what was that? And what should I do? Now you are not.
You have to give us more info. I mean, no.
Echo.
Well, this is the situation. They called me and I was running to the ward, and this is the situation now. What should I do now?
Do an echo.
Yeah.
So I thought the only explanation for this could be a pulmonary embolism, and I brought him to the cath lab, and this was confirmed. I don't know whether you can see it here. We had a PA pressure of 60/30. There was clots over here. Overall, on the right side, it looked pretty good. It was only on the left side. And at that time, the patient was stable again. So we could not do lysis here due to, we decided not to do it due to the recent arterial puncture. And as I mentioned, was stable after the initial collapse. So we gave heparin only, and the patient recovered from that. And then we had problem number 8, which was weakness of the left hand persisting at day 2. This improved over the next few days, and a patient recovered fully from discharge. So the outcome was marked clinical improvement, no permanent neurological dysfunction, no other complications, and also we did not have any other problems in the next 8 patients after this one here. So I bundled all the complications in just one single patient here. So that was my case. Thank you very much for your attention.
Thank you and congratulations.
So do you still use the muscular VSD, Horst? I use it very seldom now because it takes long to occlude and it's much more bulky.
No, I don't use it anymore. So I use mainly the AVP2 and occasionally the AVP3, which is unfortunately too small for many leaks. And in some cases, I also use the Occlutech dedicated device for parallel leaks, but that's actually a device which is preferable for very big leaks. So either the Occlutech for very big leaks or the AVPs from Abbott for the smaller leaks. And as I mentioned earlier, I always try to implant as many devices.
Yeah, the muscular VSD occluder is very porous, so it takes long to occlude in the very high pressure gradient environment.
Okay, all right. I think we lost Horst once again. So thank you very much, Horst. Antonio seems to be leaving. So thank you very much, Antonio, for having shared your cases with us today. And it's my pleasure now to ask Maximor, a good friend from Nancy, France, who will be giving his case entitled Too Much Good Could Lead to Bad. Max, welcome.
Hello, good afternoon, Habib. We are in France. It's quite a sunny day. Do you see my screen?
Yes, we do. Just go to big screen.
I think it's okay. Perfect. What I'm going to show is a very simple case. It's not as complicated or educational than the cases of Antonio or Sievert. It's just a daily practice. We perform approximately 3,000 PCI in our center, and we perform approximately around 700 FFR measurements. So it's a daily practice, and we are trained to that. So what I'm showing is a woman that is 70 years old with risk factors that are typical. And this patient had a recurrent typical chest pain and unstable angina also. And so she was referred by the hair cardiologist to our center to undergo coronary angiogram. So the right coronary artery, as you see it here, is absolutely normal. And here is the left coronary artery, where you see that the circ is not diseased. It's very tortuous arteries in this lady. And we have the impression of a lesion here in the, in the LED, you see mid-LED. I'm going to advance. We see it in different positions. So here again. So it's a lesion in a patient that has chest pain. So we did what we do routinely in our center, is to perform a FFR in such case. So here is the lesion. You see the last one showing this intermediate lesion here in the proximal LADs. So the decision was because of the multiple risk factors to perform the FFR on proximal LAD. So the problem are going to start. So we try to advance the FFR guide wire. So we were going to research. Impossible really to enter very well in the LED because of the tortuosity, difficulty of advancing the guide wire. It was an absence guide wire, so which is a good FFR guide wire. Impossible. So we tried to increase the support. It was impossible again. So we decided to place a cyan black guide wire, and from that to exchange to the FFR guide wire using a microcatheter. So we placed a microcatheter and exchange for the FFR guide wire. We did the measurement, and the measurement was negative, FFR 0.84. So we decided that there was nothing to do. The patient was placed in the ambulatory department, and we decided that it's a medical therapy. But 2 hours later, she had chest pain, ST elevation on anterior leads. The symptoms released after she received sublingual nitroglycerin, but we decided anyway to do video corona angiography because the evolution was not normal in this lady. So here, the first injection shows that she has dissected the LAD. So, and the dissection was the result of that attempt of placing the FFR guide wire. And so the LAD was dissected, and we tried, in that case, to advance our guide wire. We had an extensive dissection, hematoma, occlusion of proximal LAD, difficulty to wire the LAD, extension to the dissection to the left main and the circ during this maneuver, failure to find the lumen, dissection re-entry, and then again, we were able to find our way, and to proceed to an LAD of the left main and the LAD and left circ. And final result was to place stents in such situation in the LAD, the circ, and we lost the septal trunk after stenting of the mid-LAD. Here are the image with the stented place in the two arteries. You see that it was typical of an emergency with a lot of electrodes in this patient. So she was doing fine. I mean, the pressure was okay, and the result was satisfactory. We had advance. So here are the results, final result after stenting. So, but the story was not finished because as you see here, we have no more of that septal branch. After 24 hours, the patient developed a severe conduction disturbances on EKG due to septal trunk loss. The decision was to implant permanent dual chamber pacemaker. So this is the epilogue, a very sad complication in a patient that was almost normal with chest pain with FFR. So the lesson of that is that the FFR measurement is not always harmless. It could be iatrogenic. The FFR guide wires could be dangerous and difficult to advance the tortuous artery. And my opinion is that there is a room for improvement of FFR guide wires to increase really and improve the safety of a physiological measurement. Thank you for your attention.
Thank you very much, Max. That was very interesting. So you go from a stable condition just to check if there is anything wrong, and then you end up with stenting, pacemaker, etc. So it's but again, Max, this is our work. I mean, it happens. I mean many.
Yes, but we are sad when we have it.
Yes.
We are sad because iatrogenic complication are always something sad. You don't feel satisfied.
Yeah.
You always ask yourself, what did I do wrong? Did I have another step that could allows us to make the right diagnosis in this patient? The idea was, even in a trained center, which is our center, this kind of complication is really difficult to manage and shows that really we have to improve the technology of physiological measurement. Today, what we have in hand is not satisfactory. So every time the people are telling you should have done FFR measurement, yes, but FFR measurement has some danger.
You know, Max, thank you very much for this interesting case. Yes, I remember the statement of Spencer King, there is no simple PTI. Number two, actually, I don't like two wires, the rota wire and FFR wire. They are very difficult and needs manipulation. And even in tortuous vessels, you have to do microcatheters. Don't do it. Don't try it without microcatheters. When you see
But
the
is it,
or you leave the RT, don't do FFR or send the patient for thallium, something like this. But I agree completely with Habib. This is our job, but we learn from our complication. When you have a tortuous vessels, very difficult to pass the rota wire and very difficult to pass the FFR wire.
but for the rota wire, I mean, it's something you could understand because you prepare yourself to a complex situation. But the microcatheter use has simplified our life in
Yes, you're
wire
right.
manipulation.
You're right.
But do we intend to say, and are we going to say that in tortuous artery, we're going to place a microcatheter, exchange, and place the FFRI wire? In that case, the cost is going to increase of our procedure, unless the microcatheter are going to be sold for 10 euros.
Nuclear. I mean, cheaper to send him for nuclear study if you are afraid.
But nuclear studies are expensive.
Max,
You don't pay them, someone else is paying them. They are not cheap. In our country, they are expensive.
Max,
And
just
the
a comment.
nuclear medicine people are making a good living, you know.
Max, thank you for showing this case because I've previously dissected a circumflex irretrievably with a flow wire. And after years of using FFR, when I see these tortuous arteries that we often see in elderly hypertensive ladies, that for me is a patient that I will not do FFR on anymore until the technology improves. I use the Volcano system, straight arteries, everything, yeah, fine. But that wire is not designed to go down a tortuous artery. It doesn't work and it's dangerous. And I think you've highlighted something that is very important. And most of us, if we are honest, we have seen this thing happen and I've never seen it presented. So thank you for showing it.
Thank you, David. Thank you.
Maybe ask you a question, Max. Maybe, do you think that the dissection here was made by the wire or by the guiding catheter when driving the wire?
It was mostly slow. No, really, it was the guy.
Wire.
Because we had the section begins in the left main, so.
No, the problem is that it was a retrograde section to the left main. So really, it was in the mid LED where we were not able to cross. But I mean, the resistance were in that territory. It was not the case of Colombo. The Colombo case with a proximal dissection was something else. Really, that was a mid LED. But it could be, of course, the guiding catheter, but no, it was not that. It was not that. Thank you. I have to leave you, so sorry. It's Saturday, and we have to prepare Christmas in France. So,
Thank you, Max. Thanks so very much for being with us all the time. Thank you. And it's my pleasure now to ask Dr. Bin Zhang from China. Thank you, Dr. Zhang, for joining us. And he will be telling us about an extremely tough retrograde or recanalization, the application of ESC principle. Dr. Zhang, welcome. Is Dr. Zhang with us? Yeah, Dr. Zhang, you're on mute.
Do you hear me? Okay. Thank you very much to invite me to attend this great conference. It's my privilege to present a case. I didn't detail that I have to present a complication case, but I like introduce this case. Is something happened as well. So this is a 66-year-old gentleman with low AV function and cranial actually increased. This that means the angiogram was done in March, and that means it's quite good. But distal that means disease. The LAD is total clotted. I think this is a very simple CTOK case. But circumflex is disease as well is about 90% disease, and this is cranial LAO cranial view. We can see the circumflex disease here clearly, very tight, and then we can see the collateral filling distal RCA, and RCA is where it's this CTO disease as where we can see the middle RCA total corroded and well calcified, and this CTO compromised this distal bifurcation. This is other view. We can see the bridging corrector filled in the somewhere. And the local hospital tried to fix RCA CTO, but it's a field, even use a parallel wire technique. So I was invited to treat this RCA and LAD CTO. So we recheck the RCA is the same. Because the LAD CTO is simple, I like to start from this LAD CTO, and I transradio 7 French guiding catheter, microcatheter is a Ficlos 130, and start with a pilot 200. I think we'll finish it soon, but this pilot 200 goes somewhere. In other view, it's absolutely it's not in the LAD. So that after multiple efforts, it's still not in LAD. So I switched to the right coronary and retrograde approach to RCA. This is tip injection in septal collateral. And then they use Sion wire to close the septal, and tip injection in PDA, and find this the CTO stop to the bifurcation. After that, I use pilot 200 to close the CTO. Obviously, the retrograde wire was in the first lumen. And then I start to integrate the approach, and the integrate wire knock down, and I bring Gadzina in this segment. And after that, the retrograde wire can go into the Gadzina. And then advance retrograde microcatheter, the integrate wire run through can tip in a retrograde microcatheter, and implant the 3 stents. The final result is quite good, and this is final result. We cannot see any collateral field in the distal LAD. So I'm happy with this result, and staged the PCI had been implanted, and we recheck the LAD. There's nothing, but 1/2 hour later, the patient collapsed. So the beside the bedside, the echo showed that there's some myocardial infusion. Pericardial stenosis was done. We showed about 200 millimeters infusion. The patient recovered. So we brought the patient down to the cath lab. We check the RCA is the same, but we can see some infusion in pericardia. This is other view. And we check the left coronary artery. It's really hard to find some contrast extravasation. So because this is the other view, the cranial view, it's not much clear to see some contrast extravasation. Other view, cranial RAO, and a caudal view. So in this side, this is spider view. So what can do next step? Should we embolize it or use a balloon to tamponade it and just keep a watch or call a surgeon to help? So because in this time hemodynamic is relatively stable, so I like use retrograde PCI for this LAD CTO. This is 7 French and plus guiding catheter and Sion Breck try to negotiate the CC0 septal creature. So that Sion Breck can close. And then afterwards, I advance the microcatheter to the LAD. This is tip injection in the distal LAD after CTO, and then use UB3 wire to close the CTO. And then go to the left main. After that, I use a retrograde wire to tip in integrate the microcatheter. After that, I bring the microcatheter and the wire, integrate the wire down to the distal LAD, implant the 2 stent, cross over the LAD and pot it with 4.5 balloon. This is a final result. So we are unable to draw any pericardial infusion anymore. This is the other view and the quarter view. So I just, this is a third case. I use retrograde approach to save coronary artery perforation. Because I did not retrograde the PCI, so nowadays this kind of CTO PCI, I like to. My facility is ESC. E means CTO PCI has to be efficient and safe and cheap. The cost effectiveness should be better. How to do it? I do retrograde the PCI and trace too much. I use a lot of time. I use CC0 creature. Like this case is very difficult because there's a very extensive dissection here. But we look back at the LAD is not. There are not any very good creature from the septal to the PTA. What's more, the first septal was jailed by the stent. We can see that the stent was deployed in the proximal LAD. Like this situation, the integrated approach is much difficult. So I just use a CC0 creature to negotiate this kind of a creature and make this case a success. So regarding the septal creature, whatever you have done a lot of tip injection angiogram, there exists. So I believe any cases, if there's any LAD or RCA total carotid, there'll be some septal creature there. We can, even if it's CC0, I can use it for a retrograde approach. In the last few years, I did a lot of retrograde PCI. This year, even the pandemic happened, I still did about more than 230 retrograde PCI. Last year is about 233, and 2018 is about 231. in 2000, before the 2016, it's about 60% cholesterol or interventional cholesterol on septal. But yes, last year it's increased about 80% cholesterol or septal. And the CC0, the septal using is increased as well, and the successful rate is about 90%. So thank you very much.
Thank you
Hello.
very much, Dr. Zhang, for this very nice presentation and this new concept. I don't know if the other panel members, they have seen this retrograde approach to treat complex dissection of arteries that you have shown us. It's quite interesting. Now, this concept, I was wondering what PSC was. I thought that was the new concept of the European Society of Cardiology, because that's what the PSC stands for us. But it's nice. So efficient, simple, and cheap, right?
Yes, yes. So in the previous time, the retrograde PCI need about at least 5 hours. Nowadays, excuse me. Nowadays, just more than maybe 1 hour, less than 1 hour, and radiation become very low now because I use a EP model and even a 3.75 FPS.
Yeah, sure.
Habib, it's Farrell. I came back for this case. If I can ask a question.
Yes, please.
So I do a lot of retrograde PCI CTO as well, and I'm interested in your data on CC0 channels. For just some practical questions, why you use Xeon Black or you use a different wire, and that you use mostly for. So that's the first question. The second question is what's your average number of channels that you try per case before you succeed?
Yeah, the Xeon Black, in a few years ago, I learned from a Germany doctor. He used the Xeon Black for the epicardial cholesterol, and crossability is much better than other wires. So I try to use this one for a very tortuous septal, because his crossability is much better than a regular Xeon wire. So it's about 10 years ago, I will use filter FC as a retrograde wire to cross the septal. It's a hydrophilic wire as well. So I learned this experience from filter FC. So I think Xeon Black, the conjunctibility is much better than the filter FC. So in these 2 years, I use very much. Xeon Black is much effective to close the CC0 in a turn very fast, turn angulation very fast, can close the angulation very fast. So that is my experience.
And how many channels do you normally have to try in one case?
First of all, I can show my my slide. If it's according to the septal anatomy, if septal anatomy is good for the closing, I will choose one. Can I show you my slide?
You can share
yeah,
your
this one. Yeah, I show you.
You should share it.
Wait a moment. Wait a moment, please. Okay, wait a moment. Can you see this one?
Yeah.
So the first septal, usually I use this very often. If it's big enough and it's more than 1.5 millimeter, the diameter is more than 1.5 millimeter, and PTA is big enough, if the PTA distal can reach the apex, it's a very much chance to surfing to close this septal. So I'll just wait a moment. I think see this one. I have another. Sorry. That is in Chinese. Just to show this one. So it depends on two factors. One is first septal, the diameter. Is big enough, is type 1 septal. The second one, second factor is depends on the PTA length and the diameter. The PTA is long enough. Is if it's long, the distal PTA can reach the apical. So that I think there is it's a big chance to for the CCCLO collateral closing. Like this case, it's much difficult to say which the septal can close. We can see the visible connection in the distal septal, but it's very tortuous. So our doctor tried to negotiate this one. It should take 1 hour and failed. But I just go the first septal and tip injection, and then use Sion black to close this connection. It turn easily to go to the PDA. So that is why we use this Sion black very often.
Last question: do you use a talker or you use your fingers?
No, never use fingers. Never use.
Farrell, do you have this experience of using this retrograde approach for dissection of the contralateral artery?
Yes.
Okay.
I have.
So is it, and this question goes to Dr. Zhang, of course. So you try to go onto gradely, and when you have hard time when you go retrograde, or from the beginning when it is a very big, extensive dissection, then you're afraid of make it worse, and then you go on the other side. What is
No. I always prepare integrate approach very well, because if you go to the retrograde approach, the patient always suffering discomfort. So that we have to shorten the all procedure time, especially retrograde time. So we have to prepare very well, integrate very well.
Okay. Any more questions to Dr. Zhang? If not, I would like to thank all of you. I think this I missed some of this session. I was waiting for many weeks. But I hope that we can see the recording later on and everyone can take advantage of this. So thank you so much for having shared with us this session. It was indeed the session of the masters of interventional cardiology around the world. So we really appreciate your contribution, and hopefully we can keep this tradition for every year for Pafcic Congress. Thank you so much. We'll be closing the meeting with a keynote lecture by Thierry Corcos from France on artificial intelligence in cardiology. So do not miss it. It must contain very interesting information. Thank you very much, and have a nice weekend. Thank you.
Thank you.
Thank you.
Thank you.
Good afternoon, dear friends and colleagues. I'd like to thank Philippe Gamera for his kind invitation to participate in this meeting. I'll never get sick of Pafcic. When I say artificial intelligence, you might imagine robots such as the Terminator. Actually, with smartphones, geolocation, carpooling, email, banking, social networks,